meeting in public. Very happy to see everybody present. Apologies, we've got a late arrival from Lucy, who is our Director of Public Health, and I believe one of our GPs, Amar Guri, has now appeared. We are also absolutely delighted to have Andrew Chiltern join us, who is the recent Medical Director of Kettering General, and that is to increase the clinical input and to give us some additional secondary care views as well. So welcome, Andrew. It is lovely to have you here with us this afternoon. Do we have an on-call director this afternoon? No, we don't. Fantastic. So obviously there is a declaration of interest that is published on our website. Are there any additional declarations of interest relating to items on the agenda that we have not mentioned so far? Okay. So the next item on the agenda is the minutes from the previous meeting. So this is the meeting held on the 20th of April. If we could go through for accuracy first. So if we could go through, I'm going to use the pages on the pack for the entire meeting this afternoon rather than the pages on the individual papers. So if we start with page 4, page 5, 6, 7, 8, page 9, 10, 11, 12, 13, and page 14. Is everybody happy to record that that was a true and accurate representation of the meeting that took place last time? Yep, thank you. And then matters arising, the terms of reference for the integrated quality safety performance meeting went to the quality meeting this morning. Those were approved, but that was a meeting that Bev chaired and I attended, and so those were approved. So that action is now complete. The next item on the agenda is the Chair and the Chief Exec's report. I'm going to take this report as read. Obviously, that is a combined report. There are a couple of things that have obviously changed since this report was written, not least the national timetable with regard to the lifting of lockdown is quite different, and also the vaccination situation has changed, but we're going to have more of that in the vaccination report later on. Toby, is there anything you particularly want to draw our attention to within this report?
Thanks, Joe. Nothing from the report itself, but happy to take comments or questions as always. Just one further additional piece to kind of feed into the meeting, and it builds on what you've just described, Joe, from yesterday's national announcements around lockdown easing timelines. Corporate management team tomorrow morning will be meeting again to review our staff working arrangements over the summer period in light of yesterday's position around the further 4 weeks into that. So we will provide a further brief back into board in terms of both our office accommodation and also staff working arrangements. In short order though, Joe, we will continue to carry on in a mode where significant proportion of our workforce are continuing to work from home in line with that national messaging. And I think it's important that we show the right leadership model organisationally on that, with people only using office spaces where it's necessary to do so. Thank you.
Thank you. Any comments or questions on the Chair and Chief Exec's report? Thank you. So on this occasion, we've not had any questions from the general public. For those who wish to do so, there is obviously the ability to do that on our website, and they should be items and questions relating to agenda items rather than general queries. We haven't had any of those this month. So we're going to move on to item 8, which is the COVID vaccination update. Delighted that Anna has joined us to give us an update. Over to you.
Thank you, and thank you for the invitation. It's great to share some of the work we've been doing, so really happy to be here. Again, likewise, I'll take the report that's read, but we'll just touch on a few areas, and then with a bit of an update again as part of the news that came out yesterday and information that's emerged over the last week or two. So as you'll know, we've moved on to cohort 12 now, and we're expecting that to roll out quite rapidly as per the announcement last night, which will make things both easier for us and better for the public in terms of getting access to the vaccine. So really proud to say we're pretty close to hitting 750,000 vaccinations administered now across the county. And as the report said, that was sort of nearly 490,000 second doses within there as well. Apologies, we're at nearly 310,000 second doses now. So a huge proportion now catching up with second doses, which we know is becoming increasingly critical with the Delta variant, that's particularly reliant on that second dose to keep it at bay and keep the impact minimised. So that's been a massive team effort across the whole county. So that's been delivered between the vaccination centre, which again we're well over the 150,000 mark now, having been administered at the vaccination centre since the end of January when we opened. Our LVS's practices have been really supporting that effort as well. Huge numbers gone through those. And our community pharmacies, having come on board, have made a massive contribution and continue to increase in numbers of community pharmacies, with more wanting to come on board, which is really positive. So that's improving our coverage across. So yeah, making great progress through the cohorts, though new challenges all the time with cohorts being brought forward and second jabs being brought forward. And everybody has responded to those challenges really positively. You know, we've been at this a while now, and we have to just keep pulling it out the bag, don't we, to go, right, what more can we do? How can we push harder and faster? So we've got the various pillars of delivery. I've just named 3 of them. And hospital hubs, obviously, were really critical to getting us off and running as part of that infrastructure, really. Say our community pharmacies, just to touch on them, and they were up to 8 in this report. We've got another one coming on board as well. That's the Raven Hotel, Corby. So that will really help with our Corby population that we know we continue to need that real focus on over there. So yeah, they open on the 21st of June. We'll be making sure some good comms goes in around that. Patient feedback from the Royal Pavilion. So. And we've had, you know, a huge challenge here to set this up and convert an office building into something that sees in the region of 1,800 people a day to vaccinate. It takes around 50 to 60 staff at any one time to run the centre. We're hugely reliant on voluntary and temporary workforce, who we thank beyond measure, really, for helping us to continue to deliver the service. We're really proud that in amongst all of that, we've had some really positive feedback. Given the numbers, given the flow, people have a really good experience through here, and I'll be the first to. I have total queue obsession now. I'm continuously looking out my window at the queues, and Francis Crick, I'm sure you're all looking at the queues as well. But I'm so pleased. Very rarely do we have them, and we manage it really well. So proud of the service that we're delivering. Really proud of the safety record that we've managed to maintain and achieve as well. So we just shared a bit of the data and information on that for you. So having made all this great progress, we're thinking about what the future looks like, and obviously since writing this report, it's changed again. But there's 2 key elements to the future at the moment. So there's this short-term future, which is around, firstly, it's around second dose consolidation. So we were given the challenge about creating lots of additional capacity to bring second vaccinations forward to 8 weeks. And we're continuing to see that. So there's a very active push now to bring, particularly for the over 40s, those second vaccinations forward to 8 weeks. So it's a permission, if you like, has been granted for us to be able to do that. Not less than 8 weeks at the moment, though. So we're just trying to stick with the 8 weeks and offering as much choice as possible to the public to be able to get that a bit earlier. Surge capacity is another element. So again, over 40s having the second jab by, I think it's the middle of July now is the aim. So we need extra capacity to be able to do that. And we also need extra capacity to make sure that we vaccinate all of the 18s and over by the dates that are set out. We've racked our brains and we've thought hard and we've been really creative about how we can do that. We've at the vaccination centre, we've opened a third pod. We did that last week, which gives us capacity to vaccinate about an extra 500 people a day. So we've been doing that. We look at things like, can we put a marquee on the back of the building to increase our waiting area post Moderna? So there's lots of challenges with different vaccines that have come through as well. So you have one model that's been set up that works for AZ, then we'll have a different vaccine on board and we have to change. Potentially we're going to get Pfizer here in the future as well. So we're continuously having to adapt to that. What we're going to need to think about really hard over the next week or two is how we innovate to the new population that we're now vaccinating. So the methods that we've used so far, for example, the national booking system, that's worked really well for the cohorts up until now. Younger people don't really want to book. They just want to turn up, you know, they just want to better rock up somewhere. They don't mind queuing, for example. So it's tailoring some of the delivery methods really to the population. Some of that goes for our comms approaches and so on as well. So we're looking now, had a conversation this afternoon, how can we increase this surge capacity and also flex it a bit to make it more accessible? Phase 3 is the next bit that's under discussion. So we will be going into a booster programme. There's a couple of different options about what that's going to look like, and we've been asked to do some scenario modelling. We've met already with sort of key partners in the system to think about how that might work, and have returned some of the risk benefits options and so on to the regional team about how we might do that. So we're waiting to hear back on that. I think what we're fairly confident of is that we're going to need a vaccination centre until the end of March. So we're putting steps in place to ensure some continuity of the service there. So the three big risks for the vaccination programme, one of them is maintaining our sites. So we've got the pillars that we've described. The vaccination centre, we're confident will stay. I think we'll see a pattern of increasing community pharmacy provision as LVSs are looking, some sites are looking to focus on getting back to their normal business, which is completely understandable. So it's how we flex to that and how we meet those demands. And also for any of those LVS sites that do step back from this, to extend our massive thanks for all of the work that they've done and the contribution that they've made to the programme so far. Clinical workforce, well, all workforce, but clinical is a particular pinch point. So we've had a lot of staff who have supported us, particularly at the VC, through lockdown when they have been furloughed, volunteers who have had more time on their hands. As people return to normal, our volunteer workforce is absolutely dropping off, and that's being experienced nationally. That's being experienced by the PCNs as well. Lots of people returning to their day jobs, and they want to go out, as we experienced at the weekend, and have fun. So they cancel their bank shifts when, you know, when it's a sunny day and so on. So we need to look to a more sustainable workforce solution for the vaccination centre, and lots of that's already in progress. So we're filling a number of posts with fixed term appointments now, because we know this is a longer programme now. So that's the most sensible thing, and that helps to stabilise our service delivery. And clinical safety and oversight remains a real focus. Every day something different comes out in terms of who we can give AZ to, what the clotting risk factors are, what's this issue over here. There's the whole host of issues that pops out all of the time that we need to keep on top of, and it can be challenging to keep on top of. So that's a real key focus for us. And obviously we have the system group that looks at all the safety, the incidents, the clinical group that focuses on all of that as well. So in conclusion, it's been a massive programme, a massive privilege to be part of, and I know Chris would echo that absolutely if he was here. And I think what's been so amazing is I've never been involved in anything that has had such a scale of system working and system partnership, and everybody just jumped in the pot together and got on with this to make it work. We've got so many organisations working across his vaccination programme to make sure it's a success, and it absolutely is a success. So so just a massive thank you to everybody, including lots of people on this call who have supported us all the way. And very happy to take any questions.
Thank you, Anna. Really helpful to give your views on it and personal experience, and just my thanks as well to everybody, staff, volunteers, everyone who's got involved with it. It has been an amazing effort and continues to be so. So my thanks as well to everybody who's been involved. So from a questions point of view, over to you, Andrew. Sorry, two Andrews. Andrew Hammond.
Thank you very much. Firstly, congratulations. I think it's a brilliant job. I'm obviously a board member, but also a resident and an employer, and I've heard nothing but praise for it, and it's helping keeping our businesses going, so it's fantastic. Just one observation. I was sort of thinking particularly about the university students who will be coming into the county in September, many of whom will have only had one jab when they come in. Have we got any plans for reciprocal arrangements with sort of other areas where they've had one jab in, say, Scotland, and they're coming down to university here to give second jabs? Is that in the consideration pot? Because I noticed that we haven't got anywhere at the University of Northampton at the moment as a vac site.
Yes, so definitely. So anybody can book once the 18s are open as well. Anybody can book in through the national booking system to any centre. So so they would be able to do that. And actually, on a call earlier today, we've had exactly that conversation about a university-based pop-up. So that's definitely in the planning and in the making. And I'm speaking to a reader later this week, our qualities lead, about a whole range of pop-up options, and the university is one of those that was mentioned. Yeah.
Thank you. Important and socially active section of our society, and really important that they have equal access and equitable access to the vaccine. Ange.
Yeah, I just wanted to pick up on Anna's point. Anna, we've seen a massive reduction in any concerns or complaints coming through. It's really, I mean, it's gone down to single figures, you know, so I think that's because things are working so well. So what I would say is, if anything's changing, Anna, and you need us to have some comms in place in readiness for if you're changing, just let me know and I'll have that ready for the team so we can be really proactive in that. But we've seen an absolute dramatic decrease in any concerns whatsoever, and I think that's because it's so slick now. I think patients are really happy with the service they're receiving, so a big thank you and a well done for that.
Thank you, Anne.
Thank you. Lucy.
I wanted to echo everyone else's thanks and congratulations on an amazing piece of kind of coordination across so many partners. Anna and Chris and others, I know everybody's worked really hard, and actually that, you know, the patient satisfaction is really quite extraordinary, and I haven't seen that before. You know, you hear anecdotally that people are pleased, but actually, you know, it speaks volumes about the commitment of everybody involved. You touched just literally then, Anna, actually on something that I was going to mention, which is some of the inequalities work that's going on. So not only are there these kind of, you know, big programs of work and vaccination sites, but there have been pop-ups to obviously support, for example, some of our Muslim communities, our homeless communities, and as Anna says, there's also more in the pipeline to concentrate on some of those populations that we're still not reaching as much as we'd want to. And actually one of our biggest ethnically diverse groups that we're not reaching at the moment is actually white other. So it's many of our European, Eastern European population. So there's work going on there as well. So just wanted to make sure that Anna wasn't hiding a light under a bushel around that work as well.
No, absolutely not. And thanks to Reader, because at management group today, he shared his action plan. And, you know, the very, very many points and lines of inquiry and bits of work that are going on. We're just going to take that a bit further today in terms of what does that how does that translate into some of the actions now, like the pop-ups that we need to do to have listened, heard and acted on the feedback from communities that we've got.
And it's probably worth mentioning at the moment that obviously the comms team has been working really well across the system as well. It has been absolutely seamless, and actually reaching out to those communities, finding community leaders. The system has worked really well from the point of view of the communications, but obviously there's always more that you can do. But it has been a joy to work with the comms team.
Yeah, so just to add on to that, I suppose, Joe, and it's off the back of this younger community. I've spent lots of time with the comms team this week about actually how do we extend further. You know, Twitter and Facebook doesn't work so well for this age group. So so we've got a group of young people here at the VC gonna do a TikTok. We've had an influencer come in that's going to share some stuff. We're looking for some paid for media as well to get up on people's sites. I'm going to get Chris on Heart instead of Radio Northampton. So yeah, so just being a bit more dynamic and kind of meet the changing population really, and do things a bit differently. But comms are fully supporting us now with that. So yeah, thanks.
Thank you. Amar.
Thanks, Joe. I mean, certainly, I think like everybody's already mentioned, it's fantastic work. It's really amazing to see, and certainly thanks to yourself and Chris and everybody else involved in this big effort. And it's good to hear about how we're addressing some of the inequalities, certainly, and reaching out to those populations. Just wondering, one of the risks that you mentioned in the report and looking at the map in terms of the number of local vaccination sites reducing, and as general practice returns to normal and sort of getting a bit more warmer in primary care. In terms of the resilience within the vaccination programme to deliver this over the winter period and possibly into next year, as you mentioned, are we looking to recruit more community pharmacies, do you think, or to maybe, because I presume other local vaccination sites may drop out, or is that some part of your modelling as well, or are you anticipating them to be there till the end as well with you?
So we're absolutely working on an assumption now to a certain extent that the number of LVSs will reduce and number of community pharmacies will increase. So we know that there's a number of pharmacies who are going through the application process, and I'll be picking up with Region to get them signed off and approved as quickly as possible. So there is a really strong mitigation there at the moment for some of the reduction in LVSs, and actually the community pharmacies are really passionate about supporting this programme. So there's a real will behind there. As kind of further mitigation, and it's mentioned in the report, we have also worked with our council colleagues to identify other sites potentially, whether they be as pop-ups, whether they be temporary locations, whether we need to in the future step up another or smaller vaccination centres across the county. So there are a range of options there that are open to us, but I've got a lot of confidence in additional community pharmacies that want to come on board. Thank you.
So thank you everybody for your comments. It's possibly one of the most positive agenda items we've ever had, given the bleakness of what we've been through, and obviously some families continue to go through. So I think let's not say that we've finished this completely, but I think it is a positive light. It is something that people feel they can do, and as I say, my thanks to everybody. So thank you for presenting that report to us, much appreciated.
Thank you.
So we're going to move on to the public health report. So speaking of things to protect and support our public, over to Lucy. Obviously, we have read the report. Is there anything you'd particularly like to draw our attention to?
Thank you, Joe. So, as you say, assuming that everybody has read the report, the bits really that I have to be honest, keep trying to push anything that's non-COVID that public health are doing at the moment. But the bits that are particularly important is the roadmap to better health. So we have got the social media campaign that people will have read about, just focusing on really sort of getting people out and about, and maybe addressing some of the demons that may have crept up over the lockdown period for a lot of people. So it is focusing on 4 main areas of people's well-being, and just giving them tips and hints and sort of links into supportive services. And it really is just starting to try and talk about things outside of COVID, and indeed, where appropriate, explore how COVID may have impacted on people sort of eating well, moving more, feeling good, and enjoying the outdoors. So please do promote that as and where you see it. The other thing that's particularly relevant, I think, for CCG colleagues is the changes to the Stop Smoking service. We've listened to feedback and, you know, with the fact that actually we've seen an increase in the number of referrals to the Stop Smoking service, which has been really positive. We've taken on additional smoking support advisors. We have last year introduced vaping as one of the offers that we provide, because that is about harm reduction. Obviously, our ideal outcome is always people not having any dependency on any kind of nicotine product, but recognising that that might not be where everybody is. Then we have obviously adopted a harm reduction approach, and that's proved really, really popular. The other thing that we have done is reintroduce Champix. Now, I do recognise that obviously there is, you know, there's links into pharmacy support needed for that, and that has been successful at this point in time. But if you do find yourselves with any questions about any of the changes to the service, then obviously please do contact Richard, who is the service manager. But we've had really, really positive feedback from the participants in the programme, and indeed our successful quit rates have gone up significantly. So not only are we seeing more referrals, but then we're seeing many more people obviously go through to setting a quit date and completing their quit in that time period. There are lots more on there, but those were the two that I particularly wanted to draw your attention to, about getting people back active, and obviously getting people healthy post lockdown.
Absolutely. So this is a good opportunity to get people up and moving and motivated. Ange.
Yeah. Thanks, Lucy. There's some great stuff in here, and one of the things I picked up on was the Together for All, and yes, that we spoke about at something I'm going to talk about later on. And I was just interested, are other parts of the country using this? Because I mean, I've googled it. It looks such a good offer for our residents in Northamptonshire. Are we the first, or have we took that from somewhere else?
So no, we're not the first, but I don't think it's as widely used as you would expect, because as you say, it's a really good service. So again, obviously linked to, we actually haven't seen from the data so far an increase in suicide during the lockdown period, but obviously we recognise that the mental health implications of everything that's happened over the last roughly 18 months, you know, are going to be enduring, and therefore, you know, we do recognise people will need continued support. So I think this is a really good opportunity. Yeah. I'm really keen that we make sure that we evaluate this, because as I said, it is relatively new, although we're not the first, and therefore we need to understand how effective it is for our population.
I think as we're putting this through the crisis pillar, Lucy, so we will be evaluating it. And Joe, if I can just ask one more thing, because this is great, all the stuff, but one of the things I'd like to ask is about weight management, because a lot of the stuff I'm seeing is a lot of people have, including myself, I think everyone in COVID gained a few pounds, but there is a real obesity crisis. And I'm just wondering, we've got smoke in there, but what we're going to do about weight management?
So I didn't include it in this one, but you know, it's like we practiced this, but actually, Andrew, it's a really good question, because we're actually just signing off a whole system obesity plan. So again, we very much focused on sort of weight management and prevention, and actually we recognise the issue is much wider. We need to be engaging better with local businesses, supermarkets, etc., the workplace health offer, and as I said, so therefore we've started to pull together the plan. It's literally just going through the process of being signed off, and we want to socialise that, so I'm more than happy to bring it here next time. But one of the things that again we found from our previous weight management approach was that not everybody wants to engage in a set number of weeks with a program where you have to sort of visit in person and have weigh-ins, and obviously that also wasn't suitable during COVID. So we've gone through a process whereby we've got that feedback from service users, and we've now also commissioned online weight management services. So obviously people can dip in and out. We've also recognised that gentlemen tend to prefer that rather than going and being weighed publicly in large groups, typically of women. So it gives us an opportunity to do that. We've also engaged with organisations such as Northampton Town Football Club, again, who do a lot of work through their charitable arm around walking football and various other weight loss initiatives. So we're expanding our offer in the recognition that not everybody wants to do, for example, Weight Watchers. Popular and effective as it is, we do need to have a more diverse offer, and therefore we can summarise those changes to our commissioning process as well.
Thank you.
Thank you. So very much looking forward to hearing about those in the next reports. Toby.
Thanks, Joe. Just wanted to say, Lucy, how pleased I am to see in the paper the update on the social prescribing at scale programme. Many of people on this board have been involved in this and predecessor CCG boards for a number of years, and I have to say this is one of those programmes and pieces of work that feels to me like it almost took on symbolic importance in terms of our ability to get stuff over the line, in terms of that focus on prevention and early intervention and the wider kind of impacts on health and well-being. So firstly, I'm just really pleased to see it moving. The second thing I have to say, and in the midst of everything else, I've lost sight of this over recent time, seeing the reference there as well to the spring social enterprise having completed the tendering for local delivery partners, and just eyeballing the list of those local delivery partners, GPA from a Fed point of view, Age UK, Northampton Carers, Mayday Trust, that just on a face of it looks like a brilliant mixture and variety of delivery partners to be working with, which feels like the whole kind of spirit of what this was trying to do. So just really pleased to see that up and moving and quietly tucked in there in terms of a progress update. And I guess look forward as we get further into that, I think from kind of end of June onwards, July, in terms of the kind of wider rollout of how that actually works and operates. Thanks, Chair.
Chair, may I just add to that, please? So Toby, thank you for highlighting that. So yes, I should have gone through the whole list of updates, shouldn't I? But as you say, we've got a real range of providers. They then obviously work with the communities and employ the link workers, but they're geographically specific. So you'll find that each of those delivery partners is working on a particular locality, but because they're really diverse in their background and experience, there's a kind of an ability to share that learning across all of the providers, that, you know, that they're very much in a collaborative space and not in a competitive space, despite the fact that the tender for those initial services was competitive. So we're really pleased with the outcome. And Mayday Trust, for example, is again a sort of a social outcomes organisation. As you can see, there's also a GP federation in there. So it's really diverse, and I think we're going to get some great shared learning from it.
Brilliant, thank you. Andrew Hammond.
Thank you. Toby stole my thunder on the first point, which is to congratulate you on social prescribing, and well done on your resilience and patience. I remember the impassioned start to the whole project. The second point was just around, I'm always struck by the breadth of activity that's going on, and notwithstanding the social media campaign, which is a great initiative, I do feel that we need to get more communications out about this. Many organisations locally are doing an awful lot of work around mental health first aid. I've now got mental health first aid trainers. The Chamber of Commerce are doing a men's mental health programme all week this week. And I'm wondering if there's any sort of synergies, getting the comms team involved with the local chamber and LEPs, etc., to push on this, because I think that there are many more people who, if they knew about all this stuff, would really engage with it, and that would hopefully save time and clinicians' time further down the line. So any help I can give on that, fine, whether it's introductions and stuff, but I'm sure businesses are absolutely open ears at the moment for anything that can support their staff.
Sounds like a plan. Thank you, Andrew. Mitten.
Sorry, firstly, Lucy, this is brilliant. I won't repeat everyone what people have said. Just was wondering and reflecting on the vaccination update in this, and especially looking at health checks and what Andrew was mentioning about obesity and some of the lifestyle things. How do we align? Because we're reaching to a massive population, almost everyone in Northamptonshire, through the vaccination program. And then we've got this parallel piece of work of how we're trying to reach to some of those groups. So is there any advantage and some synergies? That was just my reflection. Because some of the fact that most workplaces will open up slowly, but workers will be coming to this vaccination program. Do we take that advantage of that, making every contact count? I'm sure you're gonna smirk when I say that, because we've tried and we've struggled with that in the past. But I'm just thinking, is there some synergy and advantage in doing it together?
So if I may, Chair, we explored this right at the beginning, actually, when the vaccination centre first opened. And actually, both from a point of view of national comms, and I'm just being sort of frank and open, but choosing my words carefully, around vaccination and testing, there was a huge amount of control. And at Northampton Sport, as well as my team, did look at whether we could provide people, even just with leaflets to take away, about other services that may be available. And at that point, it wasn't supported from an infection prevention and control perspective about the handing out of leaflets, but also just from a point of view of the kind of the control of the communication, so that people were really clear on why they were visiting, etc. They kind of didn't get distracted from wider noise. I think we're probably at a point where we could and should revisit that. So I appreciate you reminding me, actually, but I think there was a legitimate reason at the beginning why that wasn't supported, but I'm quite happy and would encourage us to, in fact, try and take advantage, as you say.
And many of those people are captive for 15 minutes, which is a long time, and a lot more time for health promotion than you normally get with most members of the general public who wouldn't otherwise seek help. So I think it's a really good point. So I think very well reminded, Mitten. So thank you for the report. Obviously lots more to come. So very much looking forward to even more public health, and I think very much taking its place where it should be within our system. So the next item on the agenda is item 10, which is operational planning. Obviously, we have read the report on this. Over to you, Sarah. What would you like to tell us?
Thank you, Chair. So I recognise there is quite a lot of information in here. I've chosen to send the whole system plan so that everybody could have a chance to read that and understand the information that's in it. So this is our NHS Northamptonshire system response to the H1, i.e. April to September planning round as set down by NHS EI. It is in response to 6 national operational planning priorities, which are listed in the cover sheet. And hopefully, given that I think saw the first iteration of this document at the last meeting, is a more intelligible version of how those priorities map to our system. We've put a lot of work in between first draft and second draft in terms of both system focus of the document, which NHS EI asked us to do, and also some quite specific issues that we picked up on, particularly in terms of elective recovery fund and various other things throughout the document. So what you have is the submitted document. This was submitted to the regulator at the beginning of June, and we're yet to have formal feedback on it, so I can't give you any NHS EI formal feedback yet. But I think very high level response, as is inevitably the case. But I think the document therefore aligned to the national priorities and with organisational detail to a point in the appendices at the back. So I'll stop there, Joe, because I wasn't going to talk through it page by page, and just ask if anybody has any questions on the document itself.
It is indeed a weighty tome if any of us were still printing this, but I think it's really helpful to see the detail. Any comments or questions on this comprehensive document? Toby.
Thanks, Chair. Just a couple of quick comments. I mean, firstly, a thank you to Sarah and team who've worked on this. And I know I say team because that's been a collective cross-system response, as well as particularly some of the CCG resource that supported the process of putting the plan together. Notwithstanding the fact that it is long and detailed, I think particularly the opening sections of it do have a thread that run through it now. So it is, if people haven't had a chance yet to fully, I would encourage people to take the time to kind of stick with it and work their way through. So the first is kind of a thank you, and I think it does what it needs to do for this and for the future well. Second couple of thoughts, it obviously raised the question at H1, and we're kind of rapidly approaching kind of halfway through the H1 part of it. There is an awful lot of content and commitment in here around delivery on a whole host of different areas. And it's kind of the question around monitoring and how do we know that we've actually done the things that we said that we're going to do. Partly because that feeds, I think, very quickly into the kind of H2 side of things in the second half of the year on planning. And although it's going to feel a bit Forth Bridgish, literally having just kind of brought this through here into governing body today, pretty much straight on the heels of this, we're going to start the process now of looking at the second half of the year. And I think that's where, for me, it really points to, we've talked about the huge success, which I didn't add to other people's comments earlier on the vaccination programme, but we all feel that it's been absolutely tremendous, as well as the system's response, all healthcare providers across the county and other partners to dealing with the last 18 months. but the kind of legacy of that in terms of what we're going through next over the next year, continuing to manage through kind of COVID response at the same time as the evolution of the vaccine programme, and then the recovery piece around particularly elective, around diagnostic weights and the kind of stuff you can see factored into the numbers here. The scale of this is kind of taking us back a lot of years to any point where we've had those kind of waiting lists, thankfully, across the NHS. And so I think it's really just a reminder to governing bodies, ever we needed it, that we're going to get into now a further round, not just for H2, but I think for next year and beyond, of what is going to be a number of years of how we deal with the legacy coming out of the last 18 months and the scale of that. And none of that detracts from the tremendous response to the last period. But there's some really stark reminders in here of what we're going to need to work through, as well as some of the kind of emotional and mental health and social impact of the last 18 months as well. So sorry to be, Joe, a little bit of a kind of bringing us down on that from a moment point of view, but I think this is a very good job for the first 6 months. I think the second 6 months and into next year and beyond, some real kind of challenging stuff, which I'm sure we'll rise to. And actually the system discussion we're going to have a bit later in kind of conference part about how we're evolving really points to the only way through on all of this for us to respond to that. Thank you.
Absolutely, and this is what is known, and we know that people have not yet presented to their GPs with all sorts of problems. So this is the known. There is even more to come. So I think this is a huge challenge for us as a system. Andrew Chilton.
Thanks, Joe. I largely agree with what Toby's had to say. I just feel it's socially responsible of me to make the statement that, and the document does address this, about the sort of mental health and state of all healthcare workers. However, the same people who are providing the elective recovery are the same people who provide, in general, the acute care as well. So they're not separate workforces, and the workforce is tired. I think getting and restoring elective activity will go some way towards addressing a lot of the mental health of trainees and of some of our, and some of our craft specialities. But it is going to be quite a long uphill struggle, I do believe. And I just think it's incumbent on all of us at a provider level, at a commissioner level, and a regulatory level to keep on focusing on the fact that staff have been under extraordinary pressure, and while it's vital that we do restore services and get back to where we need to be, there is a cost and an opportunity cost that will come with this.
Absolutely agree, and it is one of the things that will be picked up in the next item on the agenda as well, is that actually we are nothing without our people, and people are tired, and I think it's really important that we support them, and also the conversation with the public as well, because that also has an enormous effect on staff morale as well. So I think your point is extremely well made. Any other comments on the operational planning, or any final reflections from you, Sarah?
I'd just like to add to what Toby said, Joe, under this item, which is just I'd like to put on record my thanks to everybody who contributed. This is a real system effort, both from system leads, from teams across the county, across organisations, over a very short set of timescales, and everybody, I think, committed to delivery of what's in here as well. But just a thank you from me for the people and the resources that it took to produce the document you've got in front of you.
Thank you. Yeah, thank you from all of us. So the next item on the agenda is item 11, which is the Integrated Quality Performance Highlight Report. This is a double act between Ange and Sarah. We have obviously read it. I will let you decide who goes first and which comments you want to draw out of it. Over to you.
Okay. Sarah, shall I go first? Is that okay? Yeah, lovely. Okay. Thank you, Joe. I'll just start off by, obviously, we're still seeing quite a lot of pressure in our A&E department, especially at the front door. One thing I'm just going to highlight for Lucy, in terms of metrics around KGH, Lucy, I've double checked and the pilot has now ended, so that we will be reporting on metrics in the next report. We do get information daily and that's captured by our agent teams, but we're not obliged to publish those. So I've got a little narrative there just to explain it's come to the end now because that piece of work's been done. But we are seeing quite a lot of pressure actually on a Monday following the weekend, and I know that's something through the senior clinical leaders we've been picking up in terms of that liaison with primary care. I'd also like to bring to the attention around mental health, Chair, because I did say that we'd done a review about A&E in KGH in terms of behavioural issues where people were presenting with behavioural needs who actually didn't have a diagnosis of mental health at the time. I'm really pleased to say that a roundtable event took place on the 20th of May. It was a really good afternoon, 3 hours of A&E consultants speaking with NHFT and ourselves around the things that we can do to improve that. Now, that piece of work is going through the crisis pillar, and one of the things we did pick up on is what Lucy spoke about in terms of that online platform. So there is going to be some really good bespoke training as well for staff, which is really important, and also in terms about improved community communication. So some of the staff in A&E weren't aware of all the great stuff in the community that NHFT were offering. So I'm pleased to say there's going to be a presentation at the next quality committee, the system quality committee, and that piece of work is going to be ongoing through the pillar. So I did say I'd report back to you once that piece of work had completed, and I'm really pleased to say that we've seen some great progress on that. I'd like to highlight also, Chair, Broomhill Hospital. Now, Broomhill Hospital, we've been working very closely with Broomhill. We are host commissioners, so the majority of placements are out of county. So for the last 7 weeks, commissioners have dialed in to myself, and we've listened to commissioners about how their patients have been. No patients have been removed at the moment. There was a notice of proposal from CQC. So we're working very closely with the organisation. In terms of our own mental health, we're working very closely with NHFT who place our patients there. But just to say, we've got a quality improvement board. It meets again next week. We are starting to see progress in terms of their improvement plan. So one example was around nutrition. So the organisation has brought in a whole new dietary service to actually improve the patients' nutritional needs, as well as helping them with their reablement as well. So that is a risk for us, Joanna, in terms of our system. However, we do have a really close working relationship both with NHS England and the provider to work with them around their quality improvement plan. The other thing, just to bring to your attention as well, is, and I know my colleagues spoke about vaccination. I just wanted to inform people where we are with the care home vaccinations. I'm really pleased to say that we've now completed a large number of the second vaccinations. And we're working very closely with our care homes, because one of the things that we do need to do is make sure the care home tracker is completed. And I just want to remind colleagues that care homes don't really have a big infrastructure when it comes to back office functions. So we do have to work closely with them to help them to complete that tracker. So, for example, in one particular day, we worked with over 100 homes to support them. So I'm really pleased to say we've nearly completed that piece of work. We're working closely with them to encourage uptake for their staff as well. So that's something that is ongoing as well, and we will keep sighted on that. But it's very positive, Joe, in terms of the uptake for Northamptonshire and our care homes. The other thing I want to bring to your attention is something really positive. So on Monday next week, on the 21st of June, we have got the National Chief Nurse for Adult Social Care coming to visit Northampton. And that is on the back of, we presented at a really big regional event about our associate nurse programme. It was in Toby's report. I'm really pleased to say they were delighted what they saw, and they want to come and see us in Northamptonshire. And my colleagues from the council, from the 2 unitaries, are going to be with us. And I'm hoping that I'll be able to bring Deborah to see one of our specialist care centres. Because what I'm hoping to do is link in around recruitment and retention. So for Northamptonshire, it's a really good thing that we've got the chief nurse coming to visit us next week. I'm going to stop there now, Joe, and hand over to Sarah.
Thank you. Over to you, Sarah.
Thanks, Ange. So I'm not going to, Ange has stolen a couple of my highlights already in her précis, so I won't repeat them. I think really from a performance point of view, this report outlines a number of issues that we've spoken about at length in the past. It outlines the importance of the operational response described in the item immediately before it. There are a number of dashboards in here. There is a lot of red. We all know that. We have patients waiting longer than we would want. We have various issues in terms of at points where our system is running hotter than we would like. And so from a performance point of view, I think for me, Joe, I'm happy to take any detailed questions, but as I say, I think really this report demonstrates the real importance of delivering what's outlined in the operational plan we've just spoken about, and a commitment to that restoration and recovery that comes in H2 as well. I'm, like I say, happy to take detailed questions on the content of the report if there are any, but that would be my summary from a performance point of view.
And I'd like to just thank people who've been involved in developing this report. It's been a long time coming. It is really important that we look at quality and performance and the intimate relationship between those. And although it looks like a dashboard and percentages, none of us lose sight of the fact that there are real people in those figures who are having uncomfortable, unpleasant and potentially dangerous journeys. And so it is really important that we look at that interface between them and continue to monitor that as a system. So I think this report is much easier to read. I'm going to make the comment I made a little bit earlier in the quality committee that primary care at the moment only has general practice in it, and as we go towards ICS, obviously that will need to include wider primary care dentists, pharmacists and optoms. So you probably knew I was going to make that comment because it is really important, and actually that wider primary care is going to be really key moving forwards. So looking forward to seeing that area develop as we move towards that, and just really thank you for everybody who's been involved. Philip.
Yes, just to comment, Joe, if I may, when we look at these dashboards and how we record activity, one thing we don't record and which isn't measured here, and I was interested to hear that the discussions around mental health that involve the acute trusts and NHFT, but of course the majority of patients with mental health problems are dealt with in primary care, who don't appear to have been part of these conversations, and that's of real concern to me. Neither do we measure the number of consultations in primary care or the waiting times for people to see a GP and the capacity issues which we've got in primary care delivery, and what we're doing as a system to increase that capacity. So I can see the issues around the dashboards, but I think there is a lot of information which we're not gathering, which probably is available, which we should really be considering if we're looking at a whole system approach.
So, Ange, do you want to respond to that? Although before I do that, I will say that we are measuring that there are a minimum of 17,000 general practice consultations a day. We will get more data as time goes on, but you are right, general practice needs to be part of the system. Over to you, Ange.
Yeah, I'd just come back, Philip. What happened was this was on the back of, it's been quite a long time where I think the A&E department, especially KGH, wanted to really have some of those conversations with NHFT in terms of the particular service they was receiving. In fact, Nathan was involved in all of those discussions through all of them. So it was a bespoke piece of work, Philip, but I'd really welcome a conversation outside this meeting today if you think there's something we should do specifically in primary care. It was something that we were just facilitating to have some really structured conversations. So really happy to pick that up outside this meeting.
Thank you. Alison.
Ange, can I just ask a couple of questions around some of the triggers that are in the report? You've got some signals around risk in the report in relation to an increased number of SIs,
yes,
safeguarding incidents. So I'm trying to triangulate the conversation from the operation planning point Sarah's made, because to deliver the reset and the restoration on the backdrop of increasing risk is really what we're saying here. And also to deliver the reset and restoration, we need to transform to do that. That is really difficult with the workforce we're describing. So it's great to have all these reports, but all of that is signalling we've got risks that we're ready to try and change things in. I know you might not have an answer to it, but I think it's important we recognise that.
Yeah, I do actually have an answer, Alison, because we do have a system called For Risk, which we use within the CCG. I don't know if you ever seen that system. I'm not sure.
It's about how we change each system. Really, it's not the monitoring. It's what we do in terms of mitigating risk of patients as we change and try and change and transform.
I think, because what I was going to say is we've got that system, and one of the questions we're asking is how we can flex that system to match exactly what you're saying. Because what we have got is we've got CCG risks in terms of commissioning risks, and we've got system risks. So I think what you're saying is the so what and how do we triangulate together. So that's the piece of work we're doing next, Alison. I'm not sure if this particular system we've got and we've been using is going to flex, or whether we're going to have to relook at it and do something else in terms of that. So what? How does that translate? I mean, at the committee meeting we were talking this morning, I don't think you were there when we were talking about, for example, we've got a provider called Sugarman, where we did quite an intensive piece of work with that provider last year, where we worked as a CCG, we were working with them every day, and it did resolve and it did improve. So I think exactly what you're saying. I'm not sure if we've got it right yet, but it's something that we're working towards.
But I think it's less about the CCG, Ange, and more about the elective care boards and it's what was in the previous plan. It's the system grasping change and risk at the same time, not about how we monitor it.
Yeah, and I think also because we have got our system risks now, but it's how through obviously the integrated quality committee that we take it to that next level. I do appreciate what you're saying. I think at the moment I haven't got the full answer for it, but I think we are working towards mitigating against that.
Thank you. Toby.
Thanks, Chair. So a comment rather than a question. So just to say that up front, I'm not expecting Ange to kind of answer or necessarily respond to this, but more, I think it's important the board is cited on or visible the extent of work that is underway over recent weeks. There are actually several people on this call. I know Mitten, Joe, I know Metcalf and various others have been involved with in terms of how we bring together our system approach to risk and to understanding risk of harm and safety issues and the significance of those in different parts of the county, which in the midst of an enormous volume of data is often really very, very difficult to distill out the small number of things that we should be most concerned about for our population in terms of safety and harm at the moment. And so you mentioned, Ange, the kind of risk system, risk register side of things. I'm really keen for us to find a way to bring the work of the partnership of the ICS and the CCG closer together on this, so that we're kind of looking at the same material and the same, the one version of the truth kind of view into each of our different forums. And at the moment, it's difficult to pick your way through that. So there's a big piece of work underway around the kind of system risk register side of things. The second piece, though, in terms of our system quality oversight and governance arrangements, I think NHSE and I quite reasonably held up the mirror to us in our most recent system review meeting, which was a number of weeks back now, to say that from their perspective, they can see lots of the right parts in place locally, but actually how those things connect together and how kind of our safeguarding arrangements connecting with our patient experience arrangements, connecting with what we're doing within trust at the moment isn't obvious enough in terms of the wiring of some of that. So again, just to be open in this room in saying there's a lot of further work, and thank you, Angela. I know you've been working really closely with Julie Shepherd and various other folk and Mitten and others to draw that material together. And I think it might be a suggestion, Joe, perhaps for one of our future development session pieces, that we actually as a board governing body just have a look at where we've got to with those things. I know Bev has a real interest as the chair of the kind of system quality committee at the moment, but I didn't want us in the midst of the kind of work that you outlined, Ange, not to acknowledge that there are a number of key things underway at the moment, which I think there's some good progress on. But actually, they do pose some really challenging questions to us as an organisation, as a system, about where we currently are in terms of risk, harm, safety, and how visible some of those key things are to all of us in terms of the responses that we're taking.
Yeah, and Joe, can I just come back, because obviously I've only shared it with a few people at the moment because it's draft, but we have put everything in one place. In fact, I've shared it with Mitten's seen it, and I'll share it with other colleagues. I just had to get that out yesterday, just in draft. But I'm really pleased to say it does actually show our system in one place. Obviously, we're still on a journey. It's not perfect. We've still got room to go. But in actual fact, I've shared it with another system as well, just to get a peer review, just to make sure we're in the right place. NHS England were very pleased with our progress today. Again, it's not a done deal. We've still got a lot of way to go. But what I think is, Toby, I think that would be a really good suggestion. If we could do that, I would really welcome that opportunity to look at where we are now and in actual fact how we can keep improving it, because we've got building blocks, but I still think there's some mileage to go. And I know I've shared it with Mitten, and I'm sure maybe you will comment, but it was really good to see everything in one place, especially the work of the county-wide patient safety group, which is extremely well established, which has been great in highlighting the risks to the system.
And I think just to build on what Toby and Andrew said, that the System Clinical Risk Register has had input from general practice, from directors of nursing, from allied health professionals, that's actually now a much broader group building on that. So I think that's really important to recognise that this is not just a few people in a darkened room. This is a much broader system approach to it, which absolutely I welcome. Will.
Thanks, Joe. Do you mind if I ask a very specific question about MRSA and C. diff? It might be a bit too detailed, and you might want to do it outside the meeting, but is that okay?
Ask away. We'll see what happens with the answer.
All right, thank you. Well, I was thinking, like the guys have just been talking about, system risks and worrying about what might be coming. I was looking on page 144 of the pack at the MRSA and C. diff numbers, which look as though they're getting worse in, if you like, this month and the previous month, or getting, less good, shall we say. And I was turning that over in my mind. But I then looked down at page 146, which has got the separate KGH and NGH numbers and they didn't seem to match the cumulative numbers. So, for instance, on page 146, if I read it right, it's showing MRSA and C. diff as 0 for both KGH and NGH in the current month, whereas it's showing on page 144, it's showing some positive numbers, 3.4 and 40.3 respectively. And I wondered if I was misinterpreting it, or if there is something that perhaps would be needs a bit more looking at in the data.
I think you do win the Eagle Eyes prize so far for this meeting. Sarah, do you want to comment on that from a numbers point of view? Oh, you're on mute.
Yeah, from a numbers point of view, well, I will take it away and have a look at it. I've got an assumption as to what the answer is, but I'm not 100% sure. So I think the system position reflects all CCG commissioned activity, and therefore out of county hospital providers, as well as just KGH and NGH. That is my assumption. But I would want to make absolutely sure that was the case before confirming it to you. So I'm happy to take the data point away, and we'll come back to you, and happy to Joe, just circulate something to governing body as well, just for completeness, just to confirm what that issue is between the system and the two acutes in that respect.
And
that's great. That's it. Yes.
Yes.
Sorry, Joe. That's a great answer. Thank you. And then, if it is as Sarah's just explained, perhaps a thought on is it getting worse? Is that a new risk rising for us? Just some thoughts on that, or is it just a movement in the data in the normal course?
Sure.
Thank you.
And did you want to comment on that?
Yeah, I just want to come, because it's actually something I've literally just emailed Siobhan Heathfield, who's our chief nurse, this morning, to say one of the things I'm going to speaking with my other dons about is the use of probiotics in terms of healthy gut bacteria, because we have seen an increase in people receiving antibiotics, and my worry is we might see more C. diffs. So it's actually really timely that Will's asked that question. So I haven't had a chance to take it via yourself, Joe, through senior clinical leaders, to see if we've started to think about that healthy gut bacteria and making sure that we're protecting our patients. So I've literally only emailed this morning the chief nurse for our region to say I've also started to do that. You know, I've spoken to Leanne at KGH last night. I was going to speak to Sharon at NGH to see if we are seeing more C. diff and stuff like that. Should we start thinking about prescribing them in hospital and maybe in the community? So it's really timely that Will's raised that issue.
Thank you, Will. I was going to bring Andrew Chilton in with his comment about old numbers and figures in the chat box, but you have raised your hand anyway. Andrew Chilton.
So really, in terms of the old figures, what I was going to say was there's been massive improvement in many areas, you know, particularly around cancer in 62 days. We're now achieving on that. So I was just surprised that you were so far in arrears. That's been my first observation. The second one was really around MRSA. So I'll speak from the Kettering perspective. We've had a single case of we went for 5 years with no MRSA bacteremias, and we've had one single case. So MRSA bacteremia is really quite unusual, and it is always investigated as a serious incident when it actually occurs. But that's pretty impressive, 5 years without a case, which shows that these sort of care bundles that have been introduced have been quite dramatic. C. diff is going up at the moment because the use of antibiotics, especially with COVID, has increased very significantly. And antibiotic pressure on the gut bacteria is the leading cause of the development of C. diff. So we have seen more of that occurring. And I'm afraid I'm a gastroenterologist. Giving probiotics isn't going to stop this one. They're elderly, they're frail, multimorbidities, long lengths of stay. That's the group that gets it.
This might not be the time for the academic discussion. That might have to take place offline, and I look forward to it taking place. And did you want to comment on that?
Well, I wanted to comment on the data. So I know my colleague Sarah will obviously back this up as well. As I have gone back and said some of this data is quite old, and what can we do about it? And it is about the reporting cycle as well, Andrew. So I do recognise that, and I have gone back to the commissioning team to say, you know, the data, we do need to get it in more in real time. So that's as real time as I could for this report. But I think they're changing their reporting style and getting that data a little bit quicker. So I do recognise that, Andrew, and we have flagged that up to try and get data that's more realistic. I know some of the data is there for January and February.
Thank you. Mitten or Sarah, did you want to comment on the data? Were you on mute?
Quickly, if I can, Jo.
Yeah, so over to your data.
I think it's probably just important to say it's not necessarily that we don't have the data, it's that we don't have validated data. So I think just really important, as if you like, the secondary reporter of an awful lot of this data, it largely being acute and or other hospital provider data, mental health and community and primary care as well. Given we are the secondary reporter, we try to make really sure that the data we are reporting is validated rather than unvalidated. Real-time data would tend to be unvalidated data. And we would tend to leave that for the trusts to report in their own reports before it comes to our process, which, as Ange says, is quite long. I think there was a particular issue this month in terms of the timing of this report and the availability of data, but it does always lag a couple of months behind. And the reason for that is the extensive validation process to make sure that we don't put somebody else's unvalidated data into the public domain in a CCG report. So that's the reason for it, Andrew. It's always the case, but we do have, and the performance and quality conversations that we're having within the system on a day-to-day basis are based on the up-to-date data that comes out of your organisations. It's just to make sure we put absolutely validated data into the public domain here. I hope that helps in terms of explanation.
Thank you. Mitten.
Sorry, Joe, just responding to the comment Ange made about some of the work that Toby was mentioning, and really welcome that there'll be a dedicated time and session to discuss that across the system. It's great to see system dashboards rather than individual organizational dashboards, so that's quite welcome. But what I was really keen on, and just pick on what Ali said, is how do we ensure all the mitigations are truly going to be transformational? Because some of these things have been brewing in our system for long periods of time, and we've tried all the sticky plaster solutions in the past. So if we want to do something quite dramatically, then I think it'll have to be transformational. But equally bearing in mind the points that probably Andrew made around, we're dealing with a really tired set of staff. They're not dealing with fresh minds really wanting to jump in. So we just got to be mindful of those three lenses. And the final point, and I won't hone on this, I absolutely don't want to win the eagle-eyed prize from Will. Some of the mental health data, and probably it's worthwhile taking offline, it just looks really weird. There's some weird jumps from 83 to 65 and then 64 to 93. And it just almost feels like urgent has become routine and routine has become urgent in the eating disorder service. So I think it's just about how do we really triangulate, bottom it out, highlight the most important risk, and then some mitigation, because that's the only way we'll be able to look at this in a very holistic way.
Thank you. I think Will still has the prize from an eagle-eye point of view. I'm afraid you'll have to try harder, Mitten. Ali.
So I suppose this rounds up the conversation from Mitten and Ange and Sarah. So the system Quality and Performance Committee has actually got a task and finish group and a design group for a revised performance approach and dashboard. So to try and mitigate against what you're describing, so the feeds into it, the complexity behind it, how you manage risk, and that we're not having the conversation we're having today. So it's just been initiated. And that will feed through not only into CCG, but into the NHCP and the ICS as well. So it's just to say that even though we're recognising maybe some of the accuracies, the data feeds, that we're trying to do something about it transformationally in the system, which also links back to the transformation work and the operational plan and dashboards within elective care, which feed into it. So we need to rewire the whole thing and put quality at the heart of it, which is where Andrew's points were earlier on. So I just wanted to note that we're recognising transformation is required.
Thank you. So thank you for all the very helpful discussions on that item. I think useful conversations and very much looking forward to seeing how things develop moving forwards. So we're now entering the Stuart show, the part of the agenda where he gets to shine and usually has a number of items, which he does again on this occasion. So we're going to move on to item 12, which is the standard for governing body members. Obviously, you will have read this paper. I'm going to let Stuart talk to it, but for governing body members, watch out for your email and return it, please. Otherwise, I'll let Sarah Mackenzie loose on you. So please keep an eye out for your email, but over to Stuart to give you a further nag.
Okay, thanks, Joe. Yeah, so this is a timely reminder that there are standards for members of NHS bodies and CCG governing bodies. So you've got the standards here laid out for good governance. You need to understand your legal and regulatory framework and the extent to your limitations, what you have to do, what's expected of you from personal behaviours, your technical competencies and businesses practice. So they're here. Make sure you've read them. And as Joe correctly said, an email will be sent to you. We expect email confirmation back that you will uphold these standards for each and every member of the governing body. And I'll stop at that point and take any questions.
Any questions? No excuses will be accepted, but you can ask questions. Okay. Thank you, much appreciated. So we move on to the next part of the Stuart show, which is the GBAF.
Thank you. So, as everybody will remember, we did stand down reporting of the GBAF during the COVID. We then agreed we would start to step this back up from June. So this is to give assurance that we've started that process. You see, what we're looking for today, Ms. Robbie, is particularly to look at those risk areas that are identified. Are they the ones you would expect to see there? Are there anything we're missing for contribution from the governing body before the exec lead director will add to those and develop the full GBAF, firstly report into the Audit and Risk Committee and then obviously into the governing body in August. So I quote one of my lab members, which asks quite often, are these the things that would keep you awake at night? Are they the ones?
So the question is, is there anybody here who's been kept awake at night by anything CCG related that is not on that list? I don't want to know everything that is keeping you awake at night, but is there anything else that anybody can see or wants to ask questions about? Toby.
Thanks, Chair. It's a nuance on risk 7, which I think might benefit from being separated out into 2 different points. It's around workforce. So point 7 speaks to the potential risk is fairly to ensure that the Northamptonshire ICS workforce has the required capacity and capability. Clearly, we've touched, and Andrew's kind of given us a timely reminder again today from a provider perspective of the kind of pressures and strains on our workforce, and we will recognise that. I think there is also, though, a very specific CCG internal risk here to our ability to carry on discharging our functions over the next 9 months or so as we go through the ICS transition period. And in terms of things that keep me awake at night at the moment, that is one of them from both an exec as well as a wider organisational point of view. So just a suggestion, Stuart, that we might want to look at streaming those 2 things out, because I think they're both valid and legitimate, but they're slightly different in terms of their nature and also in terms of the impact they would have on the organisation as opposed to the system, and therefore some of the mitigating things we might do differently. Thanks.
Thank you. Any other comments or queries on this one? Okay. So thank you for bringing that. Obviously, that will come back again next time, but it's good to see it back on the agenda and is really important, obviously, moving forwards. The next item is the Lucy and Stuart double act of the annual report and accounts, and is a verbal update. Tell us what else we need to know. I don't mind which of you goes first.
Shall I go first with the kind
Ladies
of the
first.
general update? So we brought obviously a previous draft. We received feedback from governing body members, as well as we've taken it to CMT, to Audit and Risk. So thank you all for your feedback. The latest iteration has updated financial figures, figures with regard to remuneration, etc., which we always know go a little bit later into the year when they're included. We've also updated some of the infographics and some of the formatting. So no significant change from a point of view of the text content, but some additional figures towards the end, which obviously relate to the final accounts. And so I'll hand over to Stuart.
Over to you, Stuart.
To formally notify the governing body, the accounts with all the audit papers that need to go with it for sign off were submitted this morning before the deadline. And as previously highlighted and requested both from the governing body and the audit committee, was there only if a material change would happen would I bring anything back, and me and Graham had authority to do that. I can say there were no changes to the financial number, and there was some small wording and changes, and that was it. And it's now all formally signed off and submitted.
Well done to you and to your team for getting it in time. Very, very much appreciated. Anybody got any comments on either the annual report or the accounts? Okay, so we move on to the final Stuart item, which is the financial plan update. I'm going to assume that people have read this. Stuart, what would you like us particularly to look at?
So I'm going to do a bit of an update as well, because we had to resubmit today by 12 noon today. The main reason for the resubmission was the way they are treating the elective recovery fund nationally. Previously, that was a memo item. It is now to be included in the numbers. So we have now resubmitted as a system those numbers, and it means we are now submitting as a system a 3 million surplus for the first 6 months H1. So we have, as a system, submitted a very small surplus, that's got all the health organisations of 3 million for H1. So we do meet our requirements for H1 from the planning exercise. I think the thing to most probably highlight is, which will have also come up in discussion with our regulators, and I know is of concern for the system, is still the underlying position of the system, where we will be having a a further meeting with the regulator to agree control totals this Thursday coming. So I'll stop at that point and take any questions, Chair.
Thank you. Any questions for Stuart on the financial plan? You've stunned them into silence. Thank you. So lots more work ongoing. Okay, Toby, over to you.
Sorry, Joe, it just didn't feel right to pass this kind of item without any kind of comment into it. Really just to pick up Stuart's point about underlying position, I think the discussion around control total positions for year end and H2, Stuart's going to be key in framing some of the choices and decisions and trade-offs we're then going to need to get into a conversation about collectively. I think the system arrangements we've got, the kind of financial committee that we've got, which brings all the different partners together, is right. But I know, having sort of met last night with Simon and with Angela, the three of us are very mindful that there are things that we will need to get into the arena of making choices and decisions around, depending on really some of those parameters which will start to fall in place, I think, over the next couple of weeks once we get things like the control total positions agreed and so on. So again, it's another one of those kind of watch this space, a really critical piece of work that we'll need to come back to. And of course, that heavily ties actually into this whole discussion about planning and H2 and recovery and where we are from an elected position, because all of these things are interrelated in terms of activity, workforce and finance, and it's that triangulation that we'll need to come back through to. So sorry, Joe, I just didn't want us to move off of that item quite so briefly as that without acknowledging the significance of that, particularly from us from the commissioning part of the system for the second part of the year. Thanks.
Thank you. Couple more queries. Andrew Hammond.
Yeah, it's just a quickie. So obviously it feels really odd submitting an H1 plan at the end of Q1, halfway through the period. Is the submission for H2 going to afford the same timescale, or are we going to be pressured over the summer months to actually get something for the start of H2?
So the guidance we've received so far is that we will have to do that plan through July and August, and by the end of August we then have to have got it agreed with the regulator.
So that sounds like the answer to your question, Andrew, is yes.
And I guess the question is the capacity there, bearing in mind all the workforce discussions and also vacations?
It will always be tight on this one. I think it's going to be something that we won't get away without the deadline, but it is, I would echo Toby's, this is going to be challenging, not just for us as a CCG, but for the whole system.
So did you want to comment on that?
If I can, Chair, I think just to agree with Stuart, although the timeline is July and August, so a busy summer months for us. I think, however, it would be naive of us not to recognise the risk that largely all these people are the same people. And that's not just in the CCG, but across the system. As Andrew's already pointed out, we've had a very, very busy year, 18 months. And so I think, Andrew, to your question, I think the resource is there, but the resource is under pressure. The resource is tired. The resource has an awful lot of annual leave to use, etc., etc. And so I do think we need to be very cognizant of that risk as we manage through the summer. I think we need to do the planning for our own purposes as much as for NHS EI, and it's a valuable exercise. But we do need to be careful, I think, in terms of both looking after people and the balance of the resource, particularly as we also head headlong into a fairly significant organisational change and transition set of processes for the system, to be cognizant of the fact that that workforce bandwidth, I think, is a genuine risk, and I think we should acknowledge it. Thank you, Chair.
Thank you. Ali.
Joe, my comments are exactly the same, but I wanted to bring us back to that last conversation around is increased clinical risk and care and quality. So, Stuart, even though we've had the additionality of the elective recovery fund, that's to change and to help the workforce change, and that's just really difficult. So all roads are going back to the same place around deliverability with this.
Thank you. That's helpful. So thank you very much for the Stuart section, as ever, an absolute joy. We're going to move on to the next item, is the the contracting and procurement report. Over to you, Sarah. Obviously, we have read the report. What would you like to bring our attention to?
Thank you. So there's just a couple of things which I think are significant, most of which we've talked about, and one immediately. So the first thing I've written down is significant work for H2 planning. So again, just to reiterate in this context, the report's really clear about the plans we've got in place and the current processes we've got. But we are going to be required not just to put plans in for H2, but also to put contracts back in place. And that's with all NHS bodies and various others, which we haven't had thus far. We've had block contracts in place, largely prescribed by the centre. So there is some significant work to do, particularly for teams, not just around planning, but around transactional implementation of those plans as well. And therefore discussions about uplift finances, various other things that will inevitably play into the mobilisation of contracts for H2. So that was one of the main things I wanted to bring out. The procurement report you've got in here is simply a summary of current activity, so happy to take any questions on that if there are any. Other than that, the contract report is largely indicative of the same set of challenges as the performance report, which is inevitable. And so I'll leave it there, Joe, and take any questions. But I think it's just for me to flag that there is a huge amount of transactional workload to mobilise H2, as well as the planning for it. And this report demonstrates that, I think, as well.
We're certainly getting some recurrent themes that I will summarise at the end. Absolutely. Any questions, queries, comments for Sarah? Excuse me, slightly sticky mute button. Graham.
Yeah, hi Sarah, thanks for that. As you know, we had an extraordinary finance and procurement meeting last week, and I just wanted to check what happened as a result of that, whether there was any appeal by the bidders on the wheelchair and orthotic service, or is it still in the standstill period?
There'll be an update in our private session next, Graham.
Okay.
Thank you. Any other queries for Sarah? Thank you. So the final item on the agenda for the public meeting this afternoon is the primary care report. Over to you, Julie.
Thank you, Chair. Good afternoon, everybody. So I'll take the paper as read, but just wanted to pull out just a few points if I could. So we have just distributed 12,000 blood pressure monitors throughout all of our GP practices. That's been done on population size. So that's been quite that's great, because we had the 4,000 pulse oximeters, and now we've got the 12,000 blood pressure monitors. Some of them are ordinary ones, and some of them are Wi-Fi enabled as well, and therefore digital, which again is incredibly helpful. Some of them are just being stored, and practices are then going to be able to take them in as they need to from the storage area. So there's that I wanted to just say. And also I have quite a lot of media inquiries and MP inquiries around general practice and about it being open. And I just wanted to reinforce and reiterate at the meeting that general practice is open. And like Joe mentioned earlier, you know, on average seeing 17,000 patients a day, and that could be through several different forms, with online consultations, video consultations, telephone consultations, and face-to-face. Practices are seeing 60% of their patients face-to-face, and this is all driven by clinical need, depending on which type of appointment somebody would be offered. And also bearing in mind, you know, COVID has created an amazing platform now for this digitalisation within general practice. And I think some patients like it and some patients don't. But, you know, we didn't have video consultations, and we didn't have many, and we certainly didn't have many online consultations. And of course, the 6 weeks, it was basically within about 6 weeks, all practices embraced it throughout, the beginning of COVID. last year. So there's that. There's also the additional roles. We know that there are additional roles within general practice, a big long list of those for last year, but for this year there'll be 82 additional whole-time equivalents that will be recruited into general practice, including mental health practitioners, which I think is this, we've been waiting for this one to kind of be available, and the other is paramedics, and that will help with home visiting, help with people who need help more quickly, and therefore the paramedics will be there, for example, to be able to assist with some of that work. Also, just keeping on with the workforce around the 82, the Health Education England modelling also suggests that we've actually got quite a healthy projection of new qualified GPs that are entering Northamptonshire. So there's a projection of up to 40% by 2025. And these new starters will benefit from a first five lead. We have a first five lead already employed by the CCG, and they prioritise peer support as well as the retention of GPs within the first 5 years of their career, which is a very welcomed addition to our teams. Just moving on around the primary care strategy. So we have a primary care strategy. It was written in 2019 for 5 years up to 2024. We ran a PCCC workshop event. It was my first one that we actually did breakout sessions on Teams, so it worked actually really quite well. And everybody fed back, and we're going to refresh the strategy for the next 2 to 3 years. It will be signed off and agreed by PCCC over the summer, end of July, and then it will come back, obviously, for to the governing body as the primary care strategy. However, in essence, it does focus on general practice as with the strategy, and we need to start thinking about the wider primary care delegation that we are. There is obviously the delegation of the pharmacists, dentists, and optometrists, and if I could just say, it's compulsory delegation. So unlike GMS with the GP practices, where we could take that delegation on over 5 years, depending on where the CCG, which each CCG wanted. This is not the case. This is that everybody must take the responsibility for the contracting of our additional primary care colleagues and therefore primary care contracts. And there are approximately 277 additional contracts that we are just at the moment in discussions with about how that might be managed from a regional perspective before we get into the 1st of April next year. So hopefully that's been helpful, Joe, and I'm more than happy to take any questions. Thank you.
Any comments or questions? Yes, thank you for the comment of subject to legislation going through Parliament. Thank you for the disclaimer, much appreciated. This is, according to our best assumptions, we're confident that I'm going to use somebody else's words. But yes, absolutely, really important to recognise that this is all subject to political processes. Mitten.
Julie, firstly, thank you for that report. Just 2 quick comments, and both on workforce. Firstly, it's really welcome to see there's going to be a staff bank for primary care, and doing that. I'm just wondering, and this is a discussion we had with Mark at one of the other ICS committees, that perhaps there's a need for a system-wide staff bank, because otherwise it will be the mental health practitioner bit. You could see same staff being recirculated within the system with different titles. So how do we create, almost a system-wide staff bank? And there is some E&I resource that is available to do that on a digital way. The second bit, which links to that, I really welcome that 40% extra trainees. And as a trainer myself, I see that number increasing. One of the biggest challenges has been retaining these guys and girls in Northamptonshire, because some of them train here, we provide brilliant training facilities, and then they run away. And perhaps there's a role at the people board or something to say, how do we make Northamptonshire a much more attractive place to retain this increase we are seeing? So yeah, it's probably not to solve today, but just to signal that there is a bit more work we need to probably do on that front, such that we don't lose them. And it really, as a trainer, you feel really let down when they say, oh, you've done all the hard work for 3-4 years and off they go to London. So how do we ensure that, you know, we're really starting that whole process of, look, Northamptonshire is great, these are the reason why it's great, and this is what you can have in Northamptonshire that you can't get in empty London. So yeah, just something worth reflecting probably at a system committee.
Indeed, thank you very much for that feedback.
We don't have anything against London. We'd just rather grow our own if we had the opportunity to do that. Other regions are available, but they're not as nice as Northamptonshire. Ange.
First time today, and I've been at this since 8 o'clock on Muse. I just wanted to pick up on Mick because I think it's amazing to have 40% increase, and I'm just wondering how we unite that with the practice nursing, Julie, because we're trying to do the same in terms of encouraging second careers into practice nursing, also encouraging more placements in primary care to get people very interested at the first instance in the nursing career to stay in primary care. So I think it'd be really good if we could try and merge those things together so that we could actually have a body of trainees in Northamptonshire focused on primary care, Julie. So I think that's something I'm going to take through the Practice Nurse Forum, because I don't think they're aware of that 40% increase in our GP colleagues. So I'm really excited by that, because I think Northamptonshire is a wonderful place to work and live. It's got so much to offer, and we need to keep pushing that, because I think collectively that would be great for GPs and for primary care, because one thing that people notice is when there's a low workforce, it's harder for staff, especially when they're, you know, relying on agency or bank. They do need a substantive workforce because it does help them with planning and also education and training. So Julia, offline, I'll take that forward as well. So thank you. Great news.
That's great. And also thinking about the other, you know, additional resource and development funding that we've put through the training hub, both for nurses, for practice nurses, but also for practice managers. They're they're key, important people that we need to be making sure that we continue to help, support, develop and attract.
Yeah, lovely.
Thank you.
Thank you. Andrew Chilton.
Thanks, Joe. So yes, I echo all my colleagues' views that Northamptonshire is a wonderful place to live and work. I've got a slightly different question, and it might be a bit gritty, but I'm going to ask it anyway. There's a lot of information and metrics, quality metrics, performance metrics about the acute trusts, the community trust. Now, given that the bulk of healthcare is probably provided by primary care, or so my colleagues from primary care tell me so, I feel remarkably blinded to what the quality of care being provided within primary care is. And I'm asking the broader question, how do we assure ourselves, and as a burger of Northamptonshire, how do I assure myself that the care is of the quality that we would wish it to be?
Julie.
Thank you. Well, we do have, it's interesting actually, your question, Andrew, and maybe we do need to take this slightly offline as people who are bringing together information, because we do have quality reports that go through our risk stratification group that are specifically around general practice. So maybe there is something about how we then translate some of that into the quality report that is brought to the governing body. But to be honest with you, we have, I'm sure Joe and the GPs on the governing body would agree with me, we have a big empty space in a way around primary care data, about general practice data. It's not it's never been collected in a way that, for example, our acute colleagues and NHFT and the big providers, and we need to do that, and we need to do that systematically, and we need to be able to share that information, because it's difficult for the system to know how hot or how busy, whatever the word is, that actually general practice is, but also what the kinds of patients that they're treating and the things that they're doing. And this is a long answer to me saying we have got something called Arden's Manager, and it will be a game changer, because that will be able to provide primary care data to the system. So we need to launch that as soon as possible, because that will be, like I say, that will be a game changer in the information that we have.
It's probably also worth mentioning that the way that primary care commissioning is delegated to us as a CCG is slightly different, in that it is not a formal subcommittee of the governing body, it is a subcommittee of NHS England, and our primary care commissioning committee is held in public with the papers published on our website, and obviously Andrew is the chair. So we do have a slightly parallel system because of the way the governance of CCGs is set up, that the primary care commissioning runs a slightly different system to the other services that are commissioned. So the data isn't all in one place, but I think your point is well made, Andrew, and being able to see the entire system's data in one place very much puts general practice as part of the system rather than something that is separate, and that's extremely important for the population that we all serve. So I think the point is well made. And on time, Andrew Hammond, would you like to come in?
Yeah, just to sort of back it all up, I think that it's a very good point. We don't have dynamic data that we can actually forward plan with. I think the reassuring thing from my point of view, from a lay perspective, is where there are quality issues, they are highlighted very quickly and are dealt with very robustly. So I think that we're good at spotting problems, but it's that sort of overarching position across all the practices that actually would be great for that forward view as well, and celebrate some of the successes that we're having. So I totally agree with the need for more data. While I'm on, can I just make a point about the workforce conversations, because it's been a sort of golden thread through all of the topics today, and I'm not necessarily assured that we've got an answer other than we know everyone's busy and we have to be really cognizant of it. I don't want to cause any work of asking someone to plan for a plan and creating more work. So I guess the question is, are we confident that if a problem was genuinely arising, that we would know about it before it really manifested itself into a large problem? I guess that's directed to Toby, but I'm just feeling a bit uncomfortable that we haven't sort of closed the loop on this workforce tiredness and pressure that people have been under.
Bev, do you want to respond to that before Toby?
Yeah, it wasn't a response. I think I'm just sort of confirming my concern too for, and supporting Andrew's statement. We had a similar conversation this morning in both strategy and planning and in quality committee. And one of the actions from quality committee was to take away the risks that we'd already identified in the Directorate Risk Register, but just to make sure that they were being seen through the various workload lenses, but risk lenses, and how hot primary care is, how hot safeguarding is. And again, this afternoon, we've just heard all of those issues compounding. And I don't have a magic wand, but are we really fully sighted across the workforce through all those different perspectives? Because if they do all merge together, then what's the plan B?
And given that the question was levelled at Toby, although I don't think he's solely responsible for that, is there anything you want to comment, Toby, on that one?
I was going to say, I think there's two kind of lenses to this. There's a broader workforce piece from a system perspective, which is to Andrew's comment that sort of started off this discussion earlier on today, and has been a theme through this, which is where are we from a wider health and care and frontline and clinical and professional workforce in different settings. And of course, we have our people's board and we have infrastructure that sits on the side of that with leadership across the system looking, and of course all of our individual providers have their own responsibility in terms of workforce planning and how they support their staff. I think specifically, though, there's been a link as well through today's session around CCG internal workforce in terms of managerial capacity to be able to support both the work that we've described in terms of VACs and the kind of ongoing kind of work on that arena, as well as the ICS development piece, which we'll talk about a little bit later in comp session, which is absorbing a huge amount of time, understandably, of our resource, as well as this piece around restoration, recovery and ongoing kind of activity. And there's no easy answer to it, Andrew, other than there are two things that we have to continually do. And let's be honest, we've been juggling this all the way through the course of the last 18 months, which is constantly reprioritising. And that does mean that there are things we will need to come back to this board and to other committees from an exec perspective and say, actually, that thing we all said we were going to do isn't going to happen, or it's going to happen an awful lot slower because we've decided this either is more important or it's more urgent, or the combination of the two means that that needs to take precedence over it. So we are going to have to, we had exactly this conversation internally as an exec team on Monday this week, yesterday, in a timeout conversation, that we've now reached the point where it's not about which things are going to move at which kind of pace, it's actually which things are going to have to not happen and kind of not be progressed in that way. The second route, though, that we have through this, from a running cost perspective, we do have an element, a fairly significant element actually, of our running costs, which is not currently committed in this financial year yet, which we've been holding and I've been holding until we got to a point where it's clear enough what we think the transition work looks like in terms of ICS transition, so that there will be additional resource we need to bring in, but we need to use that very sparingly, because otherwise it will very quickly evaporate in terms of, you know, we've got several 100,000 set aside to be able to support that area of work, but that very quickly will disappear if we're not careful and very targeted how we use it. So there's going to be a need for both of those lenses in terms of how we take that work forward internally. But this is going to be a theme for the next period, because what we're not going to do is to start a process of substantively recruiting into additional roles when we know we're going into a kind of change period that we are over the next 12 months, or that we anticipate, subject to legislation, as we're saying earlier on. So I'm confident, Andrew Hammond, that we will spot and know the issues and pressure points internally. Some of the solutions to those things are not easy and straightforward. And my kind of risk register and BAF comment earlier on was, if we start to lose a small number of key people as we go through the next period, that becomes even more compounded in terms of our capacity and organisational memory. And I think that's the even bigger risk for me, that starts to become a reality over the next few months as well. So I think we need to come back and keep this on the agenda, Joe, and have further conversations both here and in other settings as well, from a board perspective on internal capacity. Thank you.
Absolutely. So thank you for your report, Julie. It seems to have sparked all sorts of other related conversations and is well received. And thank you particularly, Andrew Chilton, for your comments and observations from that point of view. So it just remains for me to share a few key messages from this afternoon's meeting. I've got four key things that I've noted. I think we recognise the fantastic effort by the vaccination teams in all four settings: mass vax, community pharmacy, local vaccination and hospital hubs. I welcome the public health support for lifestyle changes and improvements post-COVID lockdown. We recognise the quality, safety and performance risks and the challenges, especially with regard to the system workforce challenges for providers and for commissioning organisations. And we recognise the work being undertaken by member practices under significant pressure, and that they've been open throughout the pandemic, and thank them for adapting to new ways of working in the context of COVID. So thank you, everybody. For those of you joining the next meeting will start at 12:30. It is on a separate link, so you will need to log out and come back, but you have 10 minutes for a brief comfort break. For those of you not joining the next meeting, it's been a pleasure, and I will see you again next time.
Thank you.
See you then.
Thanks,
Stop recording.